So you're all very welcome this afternoon to our Slintecare webinar. I'm Gráinne Healy, Chair of Slintecare Citizen and Staff Engagement Forum, and I'm delighted that you've joined us for today's webinar, the 12th Slintecare Integration Fund webinar, part of our Learning Network event series. We are taking questions during the broadcast, so if asking a question or making a comment, please do indicate who the question is for, and we will make sure to get the answers for you. The Q&A button is at the bottom of your screen, and if you type in a question, it will come straight into us here. We're very happy to be delivering these webinars in conjunction with the Health Service Executive and with the support of IFIC, the International Forum for Integrated Care. Slintecare is about providing right care in the right place and at the right time by the right team. And in these webinars, you'll hear how the projects funded by the Slintecare Integration Funds and some HSE funded work is showing us best practice for healthcare reform and displaying how many have adapted work practices and created improved pathways while responding to COVID-19. Before we start our showcasing of projects this afternoon, I wanted to just note the departure of Laura McGahey, Executive Director of Slintecare, whom you met on many occasions during our webinar series. I want to thank Laura for her leadership and hard work, and likewise acknowledge the departure of Professor Tom Keane, Chairman of the Slintecare Implementation Advisory Council, whom you also met in one of our earlier webinars. Thanks to them both for their hard work in progressing Slintecare, and we wish them both well. So this afternoon, our focus is on frontline professionals delivering person-centred care. We are featuring presentations from 3 Slintecare funded initiatives, followed as usual by a panel discussion with the professionals involved in the showcased projects. Working in multidisciplinary teams has been key to delivering the innovations needed to deliver the Slintecare Innovation Fund objectives. Interprofessional partnerships, information sharing, and multi-stakeholder engagement across health and social care disciplines have been pivotal in strengthening integrated care and supporting and enhancing care in the community. So let's meet some of these professionals, the ones from our first project this afternoon, titled Introduction to Molecular Laboratory in Microbiology, a project working to reduce waiting times for test results for enteric diseases, respiratory infections, including COVID-19. Speeding up lab test results has never been more important since COVID-19 arrived, but for many people with conditions, the speedy arrival of test results allows for early diagnosis, early treatment, and this can mean crucial rapid identification, in particular in emergency departments, but also throughout hospital services. I'm joined this afternoon from Cork by 2 members of the project team, Introduction of Molecular Laboratory in Microbiology. I have to say that very slowly. So I'm joined by Liz Fitzpatrick, who is the Chief Medical Scientist, and Dr. Deirdre O'Brien, who is the Consultant Microbiologist, both of you from the Mercy Hospital in Cork. You're both very welcome.
Thank you.
I'll go to you first, Liz. Liz, just tell me a little bit about the project, the team. You know, I know you were involved in initiating it, so a little bit about the team, the project, and the background.
Great. Thanks very much for having us today, Gráinne. A little bit about the team. So obviously Deirdre and myself, and integral to that whole team as well was Dr. James O'Connor, who's our specialist medical scientist. And we also work closely with colleagues in other departments. So Franco Reardon, who's our antimicrobial pharmacist, and Joanne Crowley, who's infection control here in Mercy. And of course, our wonderful team in the microbiology laboratory, all the scientists and laboratory aides who are very enthusiastic and very much a part of the team. So the idea was, we were very conscious, you know, as you mentioned, that some of our traditional techniques and methods are very slow they're laborious, they're time consuming, the turnaround times are quite long. And these are obviously critical to clinical decision-making points. And about 70% of clinical decisions are made with access to laboratory results. So if you're waiting 3-4 days for a result, obviously that is, very unsatisfactory. But, it's just because those methods traditionally, they take time. So in microbiology, what we try to do is we try to identify the cause of infections. So mostly bacteria and viruses. And bacteria, what we've always had to do is we put them onto agar plates and Petri dishes. We grow the bacteria and we just wait for them to grow.
Yep.
And sometimes they don't always do what they're supposed to do, and they can take days. Viruses would always have been specialist techniques requiring specialist equipment and expertise. And we used to refer a lot of ours to the National Virus Reference Lab. And we're all familiar with that from COVID, the great work they do up there. But of course, once you're sending samples off site, then you have transport delays, you're waiting for results to come back. So again, you're up to 4, 5, 6 days for a result. With molecular techniques, it has really revolutionized microbiology. And you are now looking at detecting the bacterial and viral RNA or DNA directly from the sample. There's no identification afterwards because it's all done in one step using these equipment, and it can be done the same day. So we can do it in about 6 hours from start to finish.
Fantastic. And maybe if I could go to you, Dr. O'Brien. So Deirdre, your service works across the entire hospital. What were the challenges for the team in getting this up and running and functioning?
I suppose maybe to give some of the background of when the technology finally arrived in the laboratory. So we were getting ready to validate and roll this out and educate our users, the doctors and nurses across the wards, bed management and so on, as this change that was going to be implemented in the Mercy. And then COVID hit and everything else was put on hold. So we were incredibly fortunate to have this technology on site to really start to fit the need for the on-site testing of COVID, which was integral to how we managed. We're able to manage our patient flow, identify patients who had COVID very early on, from an infection control point of view, to be able to cohort patients who were positive together and so on. So that was probably, we actually had an unintended and unexpected benefit from being the recipient of the Sláintecare project. It couldn't have happened at a better time. We were able to hit the ground running with our COVID management that otherwise I think we would not have been able to do. So prior to COVID, when people were out and about and living their normal lives, and there was lots of various causes of gastroenteritis out there, we would find, on occasion, that there would be a patient, they would be in hospital, they might be in a few days, or they could be coming, of course, from the community, and they would have diarrhea or vomiting, and this would necessitate them being in a single room, ideally with their own toilet. And again, if it came up in a 6-bedded ward, and the concern would be that they would be infectious and they could spread it to other patients. The Mercy, like many hospitals in Ireland, has an old infrastructure. And it's not possible to put everybody in a single room with their own ensuite facility. So being able to rapidly identify who needs to be prioritized for those facilities and from those who don't is absolutely vital to the running of the health service and the function of our hospital. So one of the reasons why we wanted this technology and what the technology offered us was to be able to rapidly identify pretty much all of the most likely causes of infectious diarrhea, vomiting, gastroenteritis, and to be able to manage our patient flow. And in the past, we would have had blocked beds as a result of not being certain whether the cause of somebody's diarrhea was infectious or not. So that was one of the other main reasons why we needed this technology and why we wanted it, because we wanted to improve our bed flow and to stop beds being blocked and to prioritize our single rooms, our precious single rooms, for patients who really needed it.
Excellent, very good. Yeah, that's really useful. And you mentioned COVID. Maybe Liz, you could fill us in on the early COVID story. What was it? Deirdre has mentioned it, but I think it is worth just explaining to viewers what happened back in May 2020 that was helpful to you and the work you were undertaking.
Yeah, well, I wrote down the dates here just to remind myself, actually, because when I look back at it now and I say what we did in that short space of time was just, it was madness in a way.
Yeah.
We actually were training on the system, just super user training, James and myself, on the 14th of February. And in the background, you had all these rumblings about COVID we were hearing coming from China, and then it was spreading to Italy. And the first case of community transmission occurred on the 29th of February, as it happened in Cork. And we sat down and we said, right, this is something we need to do. So we parked the validation of the enterics and we said, we need to focus on respiratory. And respiratory at that stage was COVID, because there was nothing else there. As we now know, there was no flu, there was no respiratory syncytial virus. It was all about COVID. And the CG and the manufacturers had produced a CE marked kit for COVID testing very rapidly. They were one of the first CE marked kits available. We ordered it and then we waited until it arrived. It arrived on the 20th of March. In the meantime, we had been training up all our staff. We spent 3 days, day and night, validating the kit. And on the 23rd of March, we went live with testing. Wow. And a week later, on the 30th of March, we implemented a 24/7 service on call for microbiology so that we could have that 24/7 testing for COVID. It was, as I say, it was a bit of a madness, but you know, needs must. It had to be done. We were seeing all these pictures coming out of Italy of what was happening with COVID, and we just knew this had to be done.
Fantastic. Yeah. And I mean, I know from speaking with other people who they will tell us that there were things that they managed to get done in days that would have taken them months, if not years, pre-COVID, to get the protocols, to get agreement, to get over the red tape. But your story is another example of how people just put their heads down, decided it had to be done. And of course, for you, it meant that your Sláintecare funded initiative was put to immediate use and helped to kickstart the project, I think. Maybe I just ask a little bit about, you know, I'm interested in you know, how this kind of work supports integrated teams, integrated care. You're not just working in a lab. You have to have communications. You have to have all kinds of resources brought together. Deirdre, will you talk a little bit about that, about the challenges of operationalizing this? You know, how many teams are you working across, and what are the big issues, the challenges that you faced once you got the technology to make it work?
Yeah, well, I suppose it was everybody, and Liz knows this as well. And what was achieved when you mentioned the dates, Liz, it just seems like a lifetime ago, so rapidly. Everybody, we were under massive pressure to get these results available as well, and Liz will remember that as well. But then once we were able to do it, it was, I suppose, it was the communication. We have great communication. The Mercy is a reasonably small hospital, so and we all know each other very well. So it's very easy when it needs to be done. We can communicate very rapidly. We were also, because we were, I suppose, among the earlier hospitals who had this technology available, we were able to support hospitals in the region for a while too, while they were able to get themselves up and running as well. And that was a wonderful thing to do, to actually reflect back on that now. It was great to be able to help our colleagues at a time as well. And of course, you know, from those early days, we were able to expand it even further to, you know, we've helped with the social inclusion projects, we've helped with the homeless, we've helped with the addiction services. We were able to help, as Liz reminded me earlier, we were able to help, you know, nursing homes when they were managing their outbreaks. So we were able to help not just our own hospital of the Mercy, we also provide the laboratory services for the South Infirmary, but other hospitals in the region and the community and beyond as well.
Well done. Great stuff. So, Liz, in terms of the original intention of the Sláintecare project, what would you say are the key project outputs and the impacts and the benefits to both the hospital and the patients?
I suppose the key outputs was just the number of samples that we've tested to date. So for 2020, we tested 24,000 COVID samples. And in 2021 to date, we've tested over 24,000 samples, I believe. The enterics unfortunately got deferred because 2020 was all about COVID.
Yeah.
So that project didn't actually get started proper until the 1st of March of this year we went live. So far we've tested over 800 enteric samples to date. So that's in terms of the numbers. The turnaround times, there has been a dramatic decrease. So 99% of all enterics are now reported on the same working day, and the mean time is 8 hours. So
wow.
Previously that mean time was 3 days.
Wow.
So we've gone from 3 days to 8 hours. For COVIDs, and again, this is only a small comparison. So it would have just been while we were sending them to the National Virus Reference Lab before we were set up in-house, it was taking a mean time of 6 days to get a result back. And now 99% of COVIDs are also reported within working day. So that's quite dramatic. The impacts that this has then in terms of our patients, so we're picking up things that previously we would not have detected. And this is against a background of decreasing, say, gastroenteritis nationally, because everybody has taken on board the infection control measures, the hand hygiene,
washing your hands,
your hands,
the
face masks, the social distancing. So gastro nationally is on the decrease, but we have seen an increase in our sensitivity rate. Now, every sample that comes in gets tested for a panel of 12 different targets.
Right.
You know, there's no more pre-screening. They're automatically tested, and you can say yes or no, this person does or does not have each of these 12 organisms.
Excellent. Great. So look, thank you both, Liz Fitzpatrick and Dr. Deirdre O'Brien. Keep up the great work, and thanks very much for joining us this afternoon. So thanks to Liz Fitzpatrick and Dr. Deirdre O'Brien. Such a timely and topical project, and obviously doing great work. Fantastic numbers, fantastic outcomes, and to be able to shift from something that was taking days, 3 days, down to 8 hours, that is remarkable, even in human terms. The waiting over those days, the worry, and to be able to get results back so quickly, really fantastic for patient experience. The second project we're going to look at this afternoon is Cardiology Advanced Nurse Practitioner Heart Failure, Midland Regional Hospital, Portlaoise, a further example of the interprofessional work improving person-centred care. Heart failure is one of the major chronic diseases in Ireland today. It's estimated that up to 2% of the adult population in developing countries suffer heart failure. This rises to over 10% prevalence amongst the over 65s. Heart failure counts for 5% of all emergency medical admissions. It's more common than cancers, and it is a major drain on health care spending. Public awareness is very low on identifying common symptoms of heart failure, and the need for education programs to address this gap has been identified for heart failure patients, their families, and those managing symptoms. So what changes can be made to heart failure care to better identify it, perhaps prevent it, improve care, and reduce hospital stays for those with heart failure? A Slintecare Integration Fund project at the Midlands Regional Hospital in Portlaoise has been delivering improved access and continuity of care for heart failure patients by introduction of an advanced nurse practitioner. I am delighted to welcome this afternoon Karen Kelly, candidate advanced nursing practitioner at Midlands Regional Hospital in Portlaoise, to speak to us about the project. Good afternoon, Karen. You're very welcome.
Thanks, Grania.
So, Karen, will you start, maybe just tell me a little bit about the project and the team, and how are you going about delivering this person-centred care?
Well, the heart failure team here in Portlaoise, we actually call ourselves the heart optimization team, because it's just more of a positive way of describing it, and we like to think that we're optimizing patients' treatment, their medication, and also their quality of life. It's a small multidisciplinary team. We work very closely together, and we work very much in collaboration with each other. The patient is always at the center of everything we do, and all of our care is individualized around the patient. And we work with patients who are both have heart failure and also at risk of heart failure. Patients kind of might have hypertension or valve disease, and they're just at risk of tipping into the heart failure. So like many patients, find that term heart failure actually quite frightening.
Scary, yes.
Yeah, it's just the word failure. And although it is heart failure, I know some of the clinics call it heart efficiency and different terminology. So we just find that it's actually a nice way of calling it. And what we do here is our main priority, I suppose, is to optimize patients' heart function and their quality of life by increasing them and putting them into disease management programs, optimizing their medication, and also keeping them out of hospital, reducing readmission rates, and working with the families for their care to try and get the care where they want to be it in the hospital or be it at home. So the post that was created and funded by Sláintecare has actually come in on top of a very stretched team. I'm very privileged to be on a fantastic team. They're amazing. The consultant, registrar, the Geraldine, the CNS, they're all amazing. And what they've done beforehand is amazing. So it was lovely to have an extra clerical person and an extra nurse to actually add to the service that's already there, which kind of has increased patient access to the service. It's increased the number of patients that we can see. And it's also, I suppose, in a way, I've brought in some new care pathways that have streamlined things a little bit better.
And maybe talk about that, Karen. Describe the difference that this new post yourself has made to both the processes and the experience for the patient. How is it different?
Well, in a lot of ways, it's not that it's different. It's just that we're seeing more patients. So a couple of things that we've done is one is brought in a new care pathway that has worked very well. And it was to try, and the research all shows that if you can get a patient at an early stage of their disease, especially as an inpatient, if you can educate them on self-care, self-management, recognizing signs of heart failure, recognizing signs of deterioration, and also educate their family on it before they go home, and then start them on disease modifying therapy before they go home, and keep them in a 3-month kind of, what you would see them or talk to them nearly every week for at least 3 months to build up their confidence. So one of the things that I did was I put in a care pathway between cardiac diagnostics and ourselves, which means that any patient who's an inpatient or an outpatient in the hospital who has an echo, and the echo shows that they have a heart function of less than 40%, that echo actually comes to me or Geraldine here in the clinic, and we'll go up and review that patient straight away. We'll discuss it with the cardiology team, and 90% of the time we'll take over their care straight away. So you're not waiting for somebody to come and let us know, because everybody is very busy, and especially in COVID. So it has worked really, really well. And although readmission rates on average, I think, are maybe 60, the 60-day readmission rates in heart failure, I think, are up around the 20 to 30%. In that cohort of patients, we've actually had no heart failure readmissions, which is amazing for the patients. The feedback from the patients is amazing. You know, we also get them started on remote monitoring, which is a new thing in COVID. So we have worked with a company called Patient Empower. They are a company, they actually normally work with COPD patients and they monitor them at home. So we kind of saw a niche in this area in that they had blood pressures and a heart rate and weighing machines, which is really important for our patients. So we now have our patients going home with a blood pressure monitor and a weighing machine that automatically, it's Bluetoothed and it feeds into a portal here with us. And we're working with the company, we're the first heart failure company or clinic to use it.
And Karen, this means that they're not coming in to have those details checked. They're being done at home, and the information goes into your portal, and you can say your weight is up or your blood pressure is up, you need to tweak the meds. That's fantastic for patients not having to trek in and out, isn't it?
It's brilliant. And it also is, it's kind of, I suppose, with COVID, everybody had to change things with COVID, because you have to extend your clinic time, you have to extend the time between patients, so you can't see physically as many people in clinic, but yet the patients are getting sicker and they still need to be seen. So this has actually reduced patients' needs for coming into clinic. Now, we still bring in the patients when they're due to come in, but in the between times, it preempts us. We have one gentleman that comes to mind straight away, and he loves the technology. He gets a graph on his phone. It's red if his blood pressure is too high, it's amber if it's okay, and it's green if it's everything is fine. And we've titrated his blood pressure medication on the basis of that. And also he goes to phlebotomy then, which we work quite closely with. And he'll go to phlebotomy, have bloods done, so we can actually see from a laboratory point of view as well the effect of the tablets. So it's worked really well, and patients love it. It gives them the confidence. They feel like they're being monitored every day of the week. You know, they feel closer to the clinic, and it gives them confidence and empowers them to manage their disease at home, which is brilliant.
Yeah. And I know, I mean, obviously from the patient's point of view, feeling more in control, not have to be fetching up to a hospital, especially as you say in COVID, where a lot of people, even with chronic conditions, they were terribly afraid to come near a hospital because of COVID. And so having that outreach and that kind of community service is really useful. And I suppose one of the, you know, something good that came from COVID in terms of you being able to use this new technology. You mentioned a number of different care partners that have really come together, combining resources to deliver this project for the patients that you deal with. You talked about phlebotomy. Talk a little bit about, you know, who are the other care partners, because I know you get your referrals both from outpatients but also inpatients within the hospital.
So we would actually, I suppose, because there's two of us now, we have a stronger presence on the wards as well from an inpatient point of view. And most mornings, if we have a chance, we go around the wards and just see if there's any of our patients in, but also see if we can recognize that somebody is on a ward on IV diuretics, or if they're on a fluid balance chart, and then we just have a quick look at their chart and we'll see if they're for us. And by doing that, we have actually we've developed a new inpatient referral form for all the teams, and we've talked to them about it. You know, it takes a little bit of time for people to fully know you and recognize the service, and we also go around the ward. So we're actually getting more inpatient referrals from the medical teams, and even from the CNSs on the wards, the bed management discharge planner. We would have a very, very close relationship with the community intervention liaison nurse here. And it's an area that, again, through COVID has expanded a good bit. We would on average see about 10 patients through the community intervention team. And that has actually facilitated early discharges. It's your elderly or frail patient who can't come into the clinic. We still get we've developed a HLC review, a heart failure review form. And the community nurse goes out, they review the patient, they'll do bloods for us. We don't need the patient to come into clinic. And patients really, really appreciate that. We've had patients who've lost loved ones and just didn't feel like coming in. Sure. And we do service patients that are in, too far away. We had one gentleman that he was spending €80 for a round trip to come into clinic. We've organised community intervention team now, and it costs him nothing, and it's still done, and he loves it. It doesn't work for everybody, but when it works really, really well. And that is something positive that's come out of COVID.
Very much.
The other thing that's working really well is myself, the candidate AMP in respiratory, the AMP in diabetes. We all meet on a regular basis. We cross-refer to each other. We've actually had a couple of clinics where we've done collaboratively. So rather than a patient coming in to see the heart failure, then see the respiratory, then see the diabetic, because a lot of heart failure patients have multiple comorbidities. We come in and they can be seen by one person. I've had diabetes CNSs over here reviewing a patient when I've had a patient here, and also respiratory have come in and reviewed a patient when they've been here. We cross-share information if there's a patient in, and we'll always do a HbA1c, which is actually a diabetic
blood test. Yeah.
And the other thing we can do is for warfarin clinics, if a patient is due to have a warfarin clinic, we can bring them in and see them on the same day and just do one set of bloods.
Fantastic.
So the GPs would do everything from an outpatient comes in through Dr. Fleming. So the GPs may refer into Dr. Fleming, and if they have a patient that they're worried about because they might have worsening symptoms of heart failure, they might be at a high risk of heart failure, that referral comes straight to me, and we'll see the patients if they have the symptoms within 24 to 48 hours.
Excellent.
And if they're at risk within 2 weeks,
Karen, just finally, would you talk a little bit about the outputs? I know you had set some targets for the project around, average length of stay or waiting lists or admissions, and also the impacts of your education program. I'm interested in those. So what results have you got to tell us about?
Well, our education program has worked because, again, it was COVID. And in a way, yes, COVID made us think outside the box, but it's also brought in really different ways of working and different ways of helping a patient. It's put the patient more central. But what we've done is, because you can't have family in, or you can't see a patient with a family member, we have, in as much as we can, tried to actually get to see that family member and educate them before a patient goes home. Okay. And what we've done in some cases is we've caught them on the time they're coming in to pick up their loved one for discharge. So if their mother or their father is going home, that we'll ring them and say, will you pop into us in clinic first? And we'll give them the blood pressure monitor machine, and we'll give them the weighing scales. We'll give them a little bit of education, and developed a new kind of a patient information booklet and a diary, and we'll fill all that out here and educate them on the signs and symptoms of deterioration. And because of that, then the family are also aware of what to look at for the patient. So they know they have a contact detail for us to ring. The patient will be educated as an inpatient. I've also done education here in-house with nurses, so educating people on how to care for patients, what to look for, and also what education to give the patient going home, because myself and Geraldine are only here Monday to Friday. So if somebody comes in at the weekend, the nurses staff, we've educated some of the nursing staff here and are working on that. We've a good, I'm kind of jumping now, but we have a good relationship with the nurses in the prison service. So we have a couple of patients that are in the local prison, and the nurses there, we've done some education there. It's all been over PowerPoints being sent back and forth, with community intervention. So you'd hope that it actually has increased the education for patients and empowering them. They all actually, most of our patients would all say that they feel that they can recognize their symptoms. They all know that they can contact us whenever they need to. And it's just, I think it's reduced readmission rates, it's improved patients' confidence, which is really the main thing. And it's helped them and empowered them to practice self-care well at home.
That's brilliant. Karen, thank you so much. Keep up the great work there. And thank you so much for joining us this afternoon to talk about what really is a fascinating and very successful project by the sounds of it. Thanks very much, Karen.
No problem. Thanks a million for all your help from Sláintecare. We couldn't have done it without you. So thank you very much.
Thank you. So that heart optimization work certainly seems to be working to optimize patients' heart function, working with a variety of stakeholders to ensure that patients receive the care they need, where and when they need it. Our third project this afternoon is Age-Related Care Team from Wexford General Hospital and Southeast Community Healthcare. I caught up with them last week to hear about the work they're doing to support frail elderly people to stay safe and well. Older people are the largest users of the Irish healthcare system. People over 65 are 12.7% of the population and use 53% of inpatient beds. Increases in older age population require enhanced supports and interventions to support them, and in particular, address the needs of older, frail people. Providing expedited assessment and supports for older, frail people is the work of the next project we're showcasing, based in the Day Hospital in Wexford General, but working with the Southeast Community Healthcare Organisation, CHO5 Frailty Programme. This project seeks to coordinate and integrate acute and community services for frail older persons. Here to tell us about their work is Karina Summers at Wexford General and her colleague dietitian Aideen McGuinness, both from ARC, the Age-Related Care Team. Women, you're very welcome. Thank you for joining us this afternoon. Karina, if I can come to you first, please. Could you give us an overview of the project? What is it about? What did you set out to achieve? And who are the interdisciplinary team who are providing this integrated service?
Hi, Grania. Thanks for giving us this opportunity to speak and tell you about our project. So this sort of all started, and we wanted to start off with Wexford Acute and Community Older Person Services. And for many years, we have sort of been under-resourced, and we wanted to build on the resources that we already had in the area. So the aim of the project was to establish an interdisciplinary frailty assessment and intervention team with full integration between the acute and community sector. We followed the ICOP 10-step framework that gave us a template that enabled us to develop a whole network of care for the older adult. This allowed us to integrate various services within the networks, and this was for the service users to give them a route from one point of care to another and to make things straightforward. The team comprised of 5 disciplines, all right? There was an advanced nurse practitioner, a senior occupational therapist, senior physiotherapist, senior dietitian, medical social worker, and clerical officer. Now, from the beginning, the advanced nurse practitioner wasn't on the proposal for Sláintecare. This was a part of the Department of Health demonstrator site proposal, and we got 2 advanced nurse practitioners from this. On the proposal, we had a staff nurse, and the staff nurse was going to be based in the day hospital, and she was going to be able to deliver infusions and transfusion, and this was a key member of the team also to help with admission avoidance. The project hub was based in the day hospital at Wexford General. The day hospital functioned as sort of a coordination and information and training hub for services, and will support integration between the hospital and community services. This also allowed us for inward and outward referral pathways. And these were established for the older adult, as well as standardised documentation, communication reports and education around the area of frailty for staff, service users and their families. Every referral that we received was reviewed by the ARC team, and from that we were able to designate an assessment date for that within 2 weeks, and each patient was able to have a comprehensive geriatric assessment.
Great. And Carina, tell me, given where we are with COVID-19, did you have to do any adaptations because of the COVID, and what challenges did you have, and how did you manage to overcome them?
Well, I think starting any service has an awful lot of challenges, and probably just starting a service from basic to was sort of recruitment, and we had 5 staff to continue it, and that was quite challenging within itself. And then we had sort of communication was the second aspect that we were looking at. So for instance, between community and acute, we didn't have the same IT system. So that was another challenge that we had. Things that we forgot originally from the proposal was sort of IT equipment, just laptops, basic things we actually had forgot ourselves. Another aspect was sort of rooms. And our original proposal, we had sort of satellite clinics, but then with COVID, that came, and we couldn't go into some of those facilities because we couldn't have sort of acute staff mixing with community staff also. So when COVID did happen, we were sort of up and going probably nearly 2 months at that stage. So we were sort of just trying to recruit staff, and staff were then redeployed. But this didn't just happen once, it actually happened twice. But there was benefits in that too. With that, when we started, we had staff members to start on the second time that we got back. And then on the third time when we started back, we got to sort of review everything that we had done in the first instance, see the good things, the bad things, and then move on and learn from our experience as well. As I said to you, first when we sort of lost our satellite clinics, we wondered where were we going to go, and we had benefit that we actually got 5 rooms in Ely Hospital, and that sort of was our new hub as well as the day hospital hub, which was actually a great benefit for us and in the long run. We also had sort of the impact of sort of social distancing, the PPE, sort of increase infection prevention guidelines also. And we also had the fear of our service users. They were terrified to come to see us because we were the only people they had seen probably within 6 months. Yeah. And so that was very challenging as well. But on the positive side of things, with COVID-19 questionnaires, it came that we were able to ring the patients before their appointment, have a discussion with them. So A, they weren't fearful of coming in, and B, they were actually attending the appointment. So before that, one of our outcomes was to look at sort of the DNAs to reduce it, and we reduced that dramatically because of the COVID questionnaires. Also, when we reinstated the groups were coming at a smaller level, so it might be 4 or 5 in groups instead of larger groups, and the patients actually really, really enjoyed this. They felt like it was sort of more informal. They got a lot more out of it. They got to sort of really know the healthcare professional that was actually delivering the group as well. But on top of COVID, we had the cyber attack. Yes. So that was another challenge. But again, we overcame it. We learned from it, and we moved forward.
Very good. I'll go to your colleague, Aideen, now, if I might. Aideen, tell me then, with all of the things you had to overcome, are you on track to meet the patient outcomes and the outputs that you'd planned? And what impacts have you seen on waiting lists and waiting times, for example?
Actually, despite everything that has gone on in the last time period, we felt we've done very well with our outcomes. We started off aiming for naturally the Slintecare philosophy, holistic, comprehensive, timely intervention in a neutral place. So we're able to see people, they're not coming into the hospital. We're either doing a lot of home visits or seeing them off-site. With the new team, our waiting times, we're able to provide prompt access within 2 weeks in most cases. They're seeing all the MDT members on one visit. So it can be long on the day, but really the amount of trips to hospital is drastically reduced, as well as the waiting time for each individual service. Right. So for example, one of the geriatricians, they've had a reduction from a waiting time of 6 months to 6 weeks for their first attendance.
Super.
Outpatient attendance in general, we wanted to increase the number of new attendees to the clinic to a total of 1,200, and we achieved 2,389. So that's quite a significant improvement there. Our baseline non-attendance or DNA rate was 10%. That's gone down to 3%. It's fantastic, the advanced phone call and support that people are reassured even in advance of coming, because the administrative support is explaining exactly why they're coming before the appointment is arranged in the first place. Another key issue was in terms of people applying for long-term care when they are in the acute sector, when they're already in hospital from a crisis admission. We've managed to achieve a 12% reduction with a potential cost saving of over 440,000 euros. And that was even prior to the recruitment of the medical social worker as part of the team. So as part of our CGA, we're making sure there's early discussions with the client or with their family about future planning, talking through options, early discussions to prevent crisis admissions, thinking ahead forms, enduring power of attorney, initiating NHSS applications, all those early issues, issues to be discussed early is much better. And then to reduce delayed discharges, the aim was to reduce them by 5%, but there was a 14% reduction in delayed discharges. So we're working very closely, obviously, with the FIT team in ED, who know that we're going to be able to see these people within the 2-week period so that they can let them go home rather than admitting them for multidisciplinary support, whatever is needed from that point of view.
Great. So it sounds like you've surpassed many of the targets that you had set yourself, despite, as you say, cyber attacks and the COVID pandemic. So what kind of feedback are you getting from patients, from these people using the services? It sounds to me like they're having to make fewer visits, and yet they're getting great service, and their own health outcomes are improving. What feedback are you getting from the patients themselves?
We've had some really good positive feedback, positive testimonials. People are saying that this is just fantastic. Again, especially in the 18-month COVID period that we've had, the focus, the fear of going outside the door, the fear for so many of them. We've obviously done satisfaction surveys as well, particularly for the group education, which was both actual and virtual. And some patients have been encouraged to attend because of the positive feedback from family and friends who've attended. You mentioned that they're coming out of their home because they might be seeing 3 or 4 disciplines on the one day. We make sure to give them a cup of tea in a quiet corner, distanced corner, and they're just so happy with being able to do that and have a little bit of a chat.
Yeah, exactly. Just that little bit of social interaction, so important, especially for this age group, many of whom would have been cocooning. I know some of them hate that phrase, but they really would have been very, very separate from... Locked in, exactly. So that's super. Adrian, in terms of the model of work that you have devised here, is it scalable? And what would you need to make it sustainable?
Okay, so actually we have succeeded in that our project has been successful, and we have been accepted for long-term funding now under the ECC or Enhanced Community Care model. So it is in the process of being taken over, planned. And the biggest sustainability issue that we've come across is that whereas we had temporary posts, there will now be permanent posts available. So in order to get experienced senior staff members with permanent posts available, that's much better for the long-term future of the project. And then the other key issue, obviously, is to extend. We're based in Wexford, but to be able to extend to have a base in each of, ideally 4 different teams in each of the 4 towns in the county. to carry on further, so people can locally see somebody, locally see the MDT, and the idea of just home visits is just much more practical for everyone. Again, back to the right place, right time.
Yeah, great stuff. I'll just go back to your colleague Karina then. Karina, we've heard, the great patient testimonials that you've been getting, but I guess in short, to finish off, what difference is this new approach making to the lives of frail older people in the Wexford area?
Oh, I think it's a great benefit now, and probably some of the scenarios that come to mind. There was one gentleman that we had in here. He was a Parkinson gentleman, and unfortunately, he had great family support. He had 2 daughters who were doing everything in their possible to keep him at home. But it was actually getting to a point that they thought that maybe long-term care, like they were up at night with their father because he had a lot of involuntary movements. So this gentleman was referred into us from the FIT team. We saw him within the 2 weeks, and he came into us and he had a full CGA completed. Within that time, we put a 6-week plan in place for him to receive sort of rehabilitation, monitor the changes in his medication, do his investigations. On the 6th week, he walked out here walking with a stick. It was absolutely fabulous. It was really, really good to see that. And he actually wrote us a letter, and he hadn't wrote a letter in years. And it was just lovely to receive that letter from him.
Fantastic. That's a great story to end on. And so thanks to both of you. And I know there's a wider team there that you mentioned some of them, but great work, and congratulations on having the work recognised and the mainstreaming so that you can continue to carry it on. Thank you so much for joining us this afternoon.
Thank you.
So thanks to Karina and Aideen, the integration of services and that multidisciplinary approach. I mean, it's very clear it's working well for the frail elderly people in the wider Wexford area, and indeed their acceptance and success for sustainability under the ECC programme, allowing them to ensure that this piloted project has a future, and that's wonderful to hear. So you've heard about the work of the 3 initiatives, all funded by Sláintecare integrated funds. I'm now going to turn to a panel. A panel drawn from the initiatives are with me now, and we are taking questions. Indeed, some of you have been firing in the questions, so that's great. So I'm delighted to welcome our panelists. We're joined by Dr. Sean Fleming, who's a consultant cardiologist at Portlaoise Hospital. We're rejoined by Aideen McGuinness, the senior dietitian from ARC team in Wexford, and Liz Fitzpatrick, senior medical scientist and project lead from the molecular laboratory in microbiology at Mercy University, Cork, whom we met earlier. So you're all very welcome back. Thanks so much for joining us. Sean, I'll go to you first, if I might, just to let you in first, and thank you for joining us. We heard from your team, members of your team there on the video clip earlier, and I guess, talking about heart optimization, we're not going to use the term heart failure anymore. We've learned that from earlier on this afternoon. But on this issue, we heard about low readmission rates that you're achieving. Can you tell us a little bit more about how is that being achieved? What is it that you're doing that is actually leading to lower readmission rates?
Thank you very much, Grania, and thank you very much for the opportunity to talk about our project today. Sean Fleming is my name. As you say, I'm consultant cardiologist here. I've taken Karen's place because Karen is getting some well-deserved rest and relaxation at the moment. So in case she's watching from poolside, I just wanted to acknowledge her workload.
Hi, Karen.
And just to say quite sincerely, and thank you very much to Karen. She's put an extraordinary amount of work into this project over the last year, and really it's been a pleasure to work with her, really. We're particularly proud about the reduction in readmission. It's a really important metric of care in heart failure, and it's a very frustrating thing for patients that often they find themselves, or maybe often's putting it a bit too strongly, but certainly frequently they find themselves in a situation where they're going from admission to readmission. I think the level of readmission that we achieved, it is very low, and I think it's down to 4 elements really. The first really is the inpatient stay itself. So we work really hard at getting our patients decongested in hospitals. So if you can imagine when somebody comes in with an episode of heart failure, they have excess fluid in the body, and that fluid is usually within the lungs and down into the peripheries. They'll often present short of breath. They'll receive treatment with diuretics, and generally the way you assess that whether they're improving is by means of their clinical status, so how they feel, and by using a stethoscope. The difficulty with that approach is that it's imprecise. So about 50% of people will actually leave hospital with still some degree of congestion. And some people receive quite aggressive heart failure treatment who don't in fact have heart failure at all. So we've introduced some point-of-care ultrasound, essentially an ultrasound stethoscope, and we use that as a multidisciplinary team. So myself, Karen, and indeed the registrar, SHO, and intern on the team will all do these point-of-care ultrasounds and monitor the fluid status of our patients. And that's allowed us to send our patients home more optimized than they might otherwise. And when you send somebody home optimized, you are reducing straight off the risk of readmission. There's three other factors. There's the clinic itself. So Karen and her colleagues, Geraldine, have been really good at getting people in very early. So in the coming days after discharge, somebody will get a review. And as Karen pointed out in her presentation, they'll continue to be reviewed over that high risk period, the 3 months. I think the other factor is the sense of continuity of care. So it's the same team. So we work very closely together. So the same team will see the patient as an inpatient and as an outpatient. And that means we know them. And I think our patients learn that we're there to help them, and they trust us. And the final bit then is the self-care part. So Karen and Geraldine and indeed the whole team, we spend a fair bit of time talking about heart failure with patients. So they'll hear, a description of what heart failure is about from a number of different people, and each of us obviously will speak slightly differently. That's the nature of the way people are. So I think people learn about heart failure from a number of different sources. They get some practical advice about what to do in the situation where they're worried that they might be deteriorating, and they have a contact point crucially. So they can ring us and contact if they're concerned that there's a deterioration happening. So I think it's those elements really that are helping in terms of the reduced readmission rate.
Very good. And as you say, a combination of all of those giving you the low readmission rates. We had a question in from Pauline asking, what does the ANP skill set bring to the service in addition to the CNS role? So this is a very specific question about what is the skill set that, adds to the work you're doing?
Yeah, and it's something that we didn't. It's kind of something that's emerged over time. But I think what the CNS brings is kind of that managerial level. So you'll notice as Karen was talking there that she was talking about a number of initiatives. So, for example, the Patient Empower Initiative, the reaching out to other professional groups, the CNS role. In addition, I guess, to the clinical work. But I think it's that part of the CNS role I think that's been really helpful.
Very good. And just a quick question, the catchment area you operate in, where are you bringing patients from?
It's Laois, West Kildare, a little bit of maybe East Tipperary, south Offaly, and a little bit of North Carlow. So it's about maybe 120,000 people, I suspect, in total.
Okay, and before I go to our colleagues, Michelle and Pauline sent in similar questions asking, does the public health nurse or the community RGN, do they help? Are they engaged in the service? Are they one of your stakeholder groups?
They are. We've gone really with the community intervention team first off, I guess. I mean that's kind of been the initial contact point. I think there's an opportunity that we need to draw in the public health nurses. I would have thought a little bit more, and also our GP colleagues, and I think crucially the practice nurses as well. So there's a bit of work and there's a bit of an opportunity there, I would have thought.
Okay, thanks very much for those. I have a few other supplementaries, but I have Liz and Aideen also here, whom we spoke to earlier on. Liz, I'll come back to the Molecular Lab in Cork initiative. And in fact, Joanne Davis has just messaged to say well done to the Mercy Hospital Microbiology Lab on launching this testing and providing a 24/7 service in such a short time. So that's nice to get some compliments live on the programme this afternoon. Can I ask you, Liz, about, I guess, the impact that the introduction of this technology has had on individual patients? Let's keep the focus on the patient. What difference has it made to the patients who are getting these speedy results? How is it affecting the patient experience?
Yeah, very good question. Like, I suppose, unlike my colleagues here, we're not face to face with the patient in the sense that they're not presenting in front of us. It's their samples that are presenting in front of us. But
Indeed.
we get fed back the stories from our nursing and medical colleagues on the impact it's having on those patients. So a couple of examples, for instance, we had a patient recently who had been admitted with signs of appendicitis and was being prepped for surgery. They sent us a sample, which we put on the system straight away. A couple of hours later, we had a result that patient actually had a bacteria called Campylobacter, which was actually causing their symptoms, but it was mimicking appendicitis. Had we been using our old system of waiting for a culture for that bacteria to grow, it's particularly fastidious. It doesn't always grow. You might actually get a negative result, or at best it would take you at least 48 hours because it just doesn't grow any faster than that. So what we would have been doing was either reporting a negative result or reporting that Campylobacter, but 48 hours later, either way, that patient would have had that surgery. So they were able to cancel the surgery. The treatment plan was changed. They made a full recovery. So we avoided an unnecessary surgery in that case. And we had another example recently of a staff member, as it happened this time, who were negative by culture. It was at the time when we were doing the validation of the equipment. So we thought, let's throw this on and see. And we managed to detect a bacteria called Shigella. We sent it out to a reference lab to confirm that this was actually a true result. It was. That patient was then able to, or that staff member rather, was being monitored repeatedly until we could give him a negative result and allow him to come back to work safely. So there were just two examples of how it's having a very direct impact on patients themselves.
Yeah, no, they're really great examples. Talk a little bit about the impact, if any, on reducing waiting times. I'm thinking in particular in emergency departments where many people are left waiting in EDs because the tests have gone off and they're waiting on them to come back. So impact on reducing waiting times from the technology.
Yeah, well, and again, this is something that we've been told from our colleagues in the ED, that it is making a huge difference to how they can run their department, how they can free up their isolation facilities. So those patients are being isolated while they're waiting for results because they may have an infectious disease. So a positive or a negative result can be as useful, one as useful as the other. So a negative result frees up those rooms. The patients can be moved on and potentially they can be discharged. And a positive result means then that you're using your facilities appropriately, but either way, it's having a huge impact. And obviously for COVID, it means that they can keep patients moving. And there is a big move here in the Mercy at the moment to look at the ED and how everything is run and to see, are there better ways than we can do it, so that we're coming into winter time again, we're coming into our typical respiratory season, and is there a way that we can keep the patient flow, keep the ambulances emptying out and patients moving? So it is helping with all of that.
Yeah, great. And Liz, just maybe finally question to you for the moment. Looking to the future, do you envisage any scope for further developments for this?
Yeah, absolutely. So we're always on the lookout to see, is there any more that we could do with it? So one project that we're currently looking at the moment, and it's in relation to a bacteria called Helicobacter pylori. It causes symptoms in gastro-ulceritis, things like that. Mainly those patients have to get biopsies when they're being diagnosed. So this could prevent them having to have a biopsy. If we, again, it's based on a stool sample, doing a PCR, you can detect this bacteria. You can also detect whether it is antibiotic sensitive or resistant, so you will know how to treat them as well. And we are a major centre for gastro here in the south, so it lends itself very well to the services that we're already providing and enhancing those services. So we're just at the initial stages. We're looking at doing some kind of a project around that at the moment, but hopefully that'll be implemented in maybe the not too distant future.
Fantastic. Thanks, Liz. Adrian, come to you. Thank you for being with us again this afternoon. You mentioned in the video this one multidisciplinary team visit for patients. Will you just talk a little bit or explain to us, what does that mean in practical terms, and I suppose for the patients, what does it mean for them?
I'm sorry, I haven't heard. I can see you're talking to me, but I didn't hear that. I think I do. Oh, I've got you again. Okay. I know the question. Wait, yes. Hello again, Grania. Thank you again for the opportunity to talk about the Wexford ARC or Age-Related Care team. You mentioned about the multidisciplinary team.
Yes.
So we are all together. Initially, the referral comes into us. We triage or discuss what the current priorities are for that person, for their family, what's needed to be done. And that lets us know which of the multidisciplinary team need to see them on the day. The morning is what works best a lot of the time. So we have a one-stop shop with whichever disciplines are necessary for them. We have 3 different clinic rooms. We could have 3 people going at the one time. So depending on what the key issue for them is, perhaps if they're regularly falling, it might be physiotherapy first, occupational therapy, advanced nurse practitioner, dietitian, as needs be. We give them, mentioned already, the cuppa, very important, the break, because it is very tiring. The advantage is we've got everything in one go together. We can overlap times, like for example, Karina and myself would often have a joint session with someone. Maybe nutrition wasn't triggered as a major issue for them, but it's still worth me taking the chance to chat with them at the time anyway. And while one of us is talking, the other will be taking notes for them. So we're saving time later on at the end of the clinic. With the overlap, we're then able to prioritize the issues for them. We can come up with a joint follow-up plan. Oh, I think I should see them in 6 weeks. Does that suit you? And you go, oh yeah, okay. We obviously know clinically of benefits, say for frailty, that nutrition and physiotherapy are both important, but when you have the 2 of them together cumulatively, it's so much more important to have those. So we know of the clinical benefit, but much more importantly, we have patient and family satisfaction that everything is done in one go. And then we have the joint feedback report going to the GP or public health nurse, or perhaps to the consultant geriatrician before they have actually had their first visit to the geriatrician. So all of the delay waiting for those reports is saved.
Great. And I mean, I can see in terms of, from the patient's perspective, sitting in one place and having people come in the door and talk you through. I mean, it's a no-brainer in terms of from the patient's point of view. But for that to happen, the level of management, organizing the teams, making sure all of these teams, I can see the level of planning and communication that must go in behind it.
And COVID on top of that, cleaning everything in. If we can have the patient in one room and we take it in turns, all the extra issues that we've dealt with in the last period.
Yeah, no, fantastic. Will you talk a little bit about, future planning by the ARC team? Will you just explain a little bit what you mean by what is the future planning? What is that element about?
It's basically a conversation that we should all be having, but it's issues that we tend to step around and not want to raise. As we've had several people say, oh, Mammy is afraid that I'm afraid of shoving her into a nursing home and taking the farm away from her. That type of delicate issue, but it's important. So each of us, depending on who is dealing with that particular question in the initial CGA or the document where we have all these questions, we just discuss and we say to them openly, it's not you specifically. We have these conversations with absolutely everybody. It's not a sign that you're at the exit door or anything like that, but it's important to have considered options. Do you have a will in place? Have you thought about power of attorney, saying it again, long-term planning considered? There's a whole fear about the idea of fair deal applications, especially in rural Ireland, again, where there might be farms or other assets to be considered. It's about choice. What is their own choice? Do they want to stay at home? Are they happy that they think that there are too many issues, that they're too much of a physical burden for their family, and maybe they're happy to go to a nursing home? What's realistic? What can be provided to help them to achieve those goals? For example, private carers are always available, but a stressed out family just doesn't know where to start to look for those sort of services. Taking care of the carers as well. We've had several cases where people come into clinic and the carers are at breaking point, but they haven't had the opportunity to express that to someone in the health service to know where to go, what to do. And a couple of occasions we've been able to organise emergency respite very quickly. We've got to know local links for that, and it's recognised that we wouldn't be asking unless it really, really was necessary. And then at the same time to know that the future changes and support that can be put into place. And as we mentioned earlier, we didn't actually have our medical social worker at the beginning of it, but she's now in place, and that's just this whole aspect of care has come along in leaps and bounds. And with the whole KPI of avoidance of crisis admissions, which is a big hot problem for our health service all around the country.
And wonderful, that idea of people, coming in around maybe frailty issues, but getting the chance to talk about their lived experience, their life. They are getting older. There are conversations that need to be had. And rather than running away from that, talking to people, even what is power of attorney? What does that mean? Explaining some of these things at the end of the day for both family members and the patient themselves, just really, I think, reducing a lot of anxiety. So it's great to have that skill set in the team to be able to do all of those conversations and the wider social care that patients need.
And again, if I could say, it's not traditionally a role that, say, a dietitian would have had, but it's, again, we're overlapping with each other and stepping in to be able to support each other and be able, I'm training the others on nutrition, they're training me on cognition issues, simple exercises, all those sort of things. That's important to have the overlap.
Great. Thanks a million. I'm going to put a question to the three, if Liz will come back on there, to Sean, Aideen and Liz, and maybe go back to Sean first of all. The three of you have been involved in, initiating, developing, leading really significant projects. Sean, go back to you first. What are the key ingredients for successful project management? I'm sure there are people, we've a couple of hundred people on this afternoon listening to this. I'm sure some of them are at the outset or even have an idea for an innovative project. What have you got to say to them about, really there are a couple of key things for successful project management. In your view, what would the advice be you give to people?
Yeah, thanks, Grania. I've had a chance to think about this. I think the first off is the management piece, because as clinicians we often don't speak the management world particularly well, and we don't understand it. So I think certainly here we really benefit from the Director of Nursing, Sandra McCarthy, who took a great interest in this project from the very start. And I think you need somebody like that who can kind of guide you through, who's got an understanding of what the issues are in terms of, I suppose, setting targets, understanding where funding can come from, and I suppose putting that kind of management understanding around what your clinical idea is. I think the other thing I'd say is build on what you have. So we had a heart optimization clinic here. It was originally Anne-Maria Keenan, who was the nurse who started it first, and then Geraldine Kelly, who started with us recently and is still with us. And also we had a cardiac diagnostic department. I have one with Niamh Harding as the chief technician. And I guess we had an understanding then of where the clinical gap was. So we were in a position to kind of, to develop the service. And I think having that kind of understanding is important rather than starting on something completely new. I think the other points really quickly would be embedded in the MDT, embedded in the service, work together and schedule time together. So we schedule maybe 90 minutes a week where we all sit together and discuss the patients. And I think that's really important from the very start. It helps everybody's learning. It makes sure we're all on the same page. I suppose there's three other things just in terms of the planning. I think make sure that there's flexibility there. I think plan to be wrong. So plan that when you start implementing your plans, that you learn as you're going, and that maybe what you initially set out, it maybe not what you need to be doing. I think that's one of the great difficulties we have as clinicians, because of course you guys in Slintecare need targets, and that's right. I mean, we need to have people examine what we're doing, and we need to show that we can show outcomes, but that's not naturally what we do. We don't naturally think in that way. So sometimes we set them too ambitiously, sometimes we set them in the wrong area. So some flexibility is really useful. Final 2 points then, database. I think that was one thing that we really need to think about a little bit more, is just making sure we're capturing our workload from an audit point of view, and also to show the value of what we're doing. And I think the final bit then, which has been touched on, is sustainability. And I think that's particularly an issue where you have smaller teams. I think a lot of the Slintecare products do involve smaller teams. So it's trying to design work that is not so onerous that people don't want to do, but yet fulfilling. And also, I guess it's a more general, I suppose, point for Slintecare itself, particularly when we're thinking about community hubs now, that idea may work very well in cities, but in rural areas where you may be duplicating services on a hospital site and then within a community site, it may be a less good way of thinking about it. But I guess that's an area that we'll probably have a discussion about in the coming months and years.
Indeed. That's great, John. Thank you.
Okay,
thank you for sharing your experience on that. Liz, we come to you. What have you learned? What can you share? Possibly reflecting on some of what John has said, but from your own view, what makes for good project management?
Yeah, I'd have to agree with everything Sean has said there. And actually, I mean, a lot of the points that I'm going to make are going to be, exactly the same. I suppose to start with, it's maybe, not to underestimate the resources that you're going to need for your project. And in particular, I'm thinking of staff resources. So in our case, we've worked very much with, equipment, reagents, things that are very easy to cost. And it's very easy to work around that part. And you probably maybe tend to focus on that part of the project and then maybe underestimate the workload level that's required to put into it. And that's probably where we struggled a little bit, and might necessarily be used to the world of project management, reporting, how it's done, and that probably took a lot more than we originally estimated that it would. Also, getting the team involved. Critical, from day one, that everybody knows what you're trying to achieve, that they're all on board, they're enthusiastic, they want to be involved. And that makes such a difference. If they're there from the beginning, then you're not trying to go back afterwards and kind of, trying to, get them on board. And I suppose the other thing really is to just be prepared for the unexpected. You just, with all the best planning in the world, you never know what's going to happen. For instance, a worldwide pandemic.
Exactly.
Whoever thought we'd have that? And, just being able to roll with it and, not to beat yourself up. If things don't go the way you thought they were going to go, the way you had anticipated, you react to that at the time and, you do your best to actually deal with that and keep the project on track. Maybe not in the direction you had originally thought it was going to be, but, it's all good at the end.
Yeah, and certainly some of the projects that we've showcased here over the last year, a lot of the project leads saying, we had some unexpected outcomes, things we never dreamed we would get, good stuff. And whether that was because of the pivots people did because of COVID, or just stuff happens in projects that you really can't plan for sometimes. And maybe it speaks back to Sean's point about there is need for a flexibility both in our heads, but also in terms of what it is we're delivering. Aideen, come to you, the same question. Are there lessons to be learned, stuff that you'd say, look, this is what makes for good project management delivery?
Definitely the one you've just mentioned, that projects change. Sean and Liz have said already, to be flexible, because certainly the people who set the key outputs or targets that we had to input into the Sláintecare report weren't necessarily the things that we were looking at as we had developed with time. Yes, we did them, and actually, as I mentioned already, our figures were actually very good, but they're not the key things that we would have put in now if we were preparing the proposal. One of the key problems we had is that the staffing has been temporary, and keeping people in those posts has been difficult. Because if somebody gets a permanent job elsewhere and then you're recruiting somebody for maybe just 3 months left up to the project end date, we've come across that in several disciplines. Because it's such a multidisciplinary thing, getting the whole MDT involved as early as possible in the planning, because although we have a good understanding of each other's roles, it's really not as good as it could be. And then there are key things that are missed out. Somehow speech language therapist got missed out in our proposal. As Karina mentioned earlier, laptops, we never actually thought of those early enough, and then there was this little pandemic thing, and there was a whole demand for working at home, so it's taken a while to get things going. To be honest, because we were just discussing this morning, even though we're, as an MDT, we know each other well, but at the early days there is the certain overlap. We stepped on each other's toes, but we were able to discuss and clear the air and deal with whatever the topic is, and we got to the stage where we're a really close team working really, really well. One thing is, we know really well what we're doing. It's making sure that the rest of the wider hospital and community team know and really understand and appreciate exactly what the benefits can be of getting us involved, and just that whole linking, making sure that people understand what we are doing.
And I think especially, I mean, within teams, but certainly across disciplines, the communication is crucial. And a lot of that usually is the face-to-face stuff. And that again has been a challenge in COVID.
It's been so much more complicated in the time we've had, that the plans we had, say, to go out and meet with the public health nurses locally, we just haven't been able to do with that. It's communication, it's emails, and doing videos that we've sent, and that type of thing. And again, everyone is too busy to do that sort of, it's another email that's come in, as against actually having that once-off face-to-face meeting.
Yeah, great. And I just have a question that has come in for the ARC team. So while we're on, are ARC multidisciplinary teams all stroke-specific staff?
No, not at all. No, stroke is only a very, to be honest, the stroke pathway would be different. They go to a local rehab unit of other care. We are just general care of the over 70s for any issue that comes up that needs more than one discipline to deal with. Great. And say more than one discipline, but we generally get 3 or 4 or 5 disciplines involved without going through the traditional referral pathway. For example, with me as a dietitian, I normally wouldn't be seeing a fraction of these people, but yet with most of them, there are things cropping up, like they're having difficulty doing some of the food preparation at home. Constipation, such a big issue. I just at least 35% from a report I did have that issue. But the traditional role would not have been referring for that particular problem to a dietitian. So we've been able to catch that and deal with problems early, hopefully, or for some of them early.
Yeah, great. Okay, I have a comment in Deirdre King, who wants to send congratulations to each of the 3 teams that we've heard about today. Fantastic work, she says, and I think that echoes our own view here from the office. I want to thank our panelists. Really interesting work, really interesting conversations from professionals working with other professionals and really stepping up to the mark, and in most cases actually delivering more than what the project original applications laid out. So I want to thank all of our guests, the panelists, those who featured in the videos earlier. Well done, all the great Slintecare project work as it continues. Today's emphasis on frontline professionals delivering person-centered care has shown us the level of inter and multi-team engagement that goes into ensuring person-centered care is delivered in the right place at the right time by the right team, the hallmark of Sláintecare. Thank you to all of the team here who helped us produce this session: Rosaline Harlan, Muriel Farrell, Ciara Eustace, Lindsay Dre, Ingrid Doyle, Erica Kinsella, Suzanne Lynch, and Tom Jukes, our technology guru. You can watch this webinar back or recommend it to your colleagues. It will be available on the Slintecare website, so do send us your feedback. The questions we didn't get to answer in the webinar, we'll hopefully post in the coming days for you. So from me, Gráinne Healy, from everyone as part of this afternoon's webinar, thank you so much for joining us. Continue to stay safe, wash your hands and hold firm. Thank you, everyone.